Yeah, okay, so we are live on YouTube now. So I welcome you all to this 11th IAP PG Clinic case presentation this year. And today we have a case of short stature with dysmorphism. Dr. Amla, who is a JR3 in AFMC, would be presenting the case. And Lieutenant Colonel Manish is our mentor. Today we have experts with us, Dr. Anand Deshpande sir, who is a senior consultant pediatrician at Dinanath Mangeshkar Hospital. And we have Dr. Sajili Mehta, who is a pediatric endocrinologist. She is based in Pune. So I welcome you all, and we should start the case. Dr. Amla, please start the case presentation.
Good afternoon, sir. I'm Dr. Amla, pediatric from AFMC. Please, my case is 8-year-old boy, second one of a non-consanguineous marriage.
Your voice is there echoing.
I think
not at all clear.
Yeah, don't use the Bluetooth. Don't use the headset. You can directly speak into the mic. Don't use the headset.
It is echoing. There's a lot of echo. And I can start now again. Let's see.
So my case is an 8-year-old boy, second born of a non-consanguineous marriage, resident
We
of
still have lot of echo. Dr. Amla, are you on two devices? If you are on two devices, this problem can come.
No, sir, on one device.
So there is a lot of echo. I think there is somebody nearby you on one more device.
Lot of echo.
Too much echo. Yeah, too much echo. Because when we checked earlier, there was no echo.
You are on which device?
Sir, I'm on my laptop.
Okay, now it seems better. Can you start? We can start now.
Yes, sir. Today's my case in an 8-year-old boy, second born of a non-consanguineous marriage, resident of Hadapsar, Pune, informant being mother, and she studied up to 7th standard and reliability is good. Presented with the complaint of inability to gain height as compared to peers since 1.5 year of age. And but at 1.5 year of age, mother also noticed that the child is thin and small compared to his peers. And when sought.
Since 1.5 years of his age or since 1.5 years?
Since 1.5 years of his childhood, sir.
His age. Up to 1.5 years, he was growing well.
Yes, sir.
Okay.
Apparently asymptomatic till 1.5 years of age. And inadequate gain in height persisting throughout the early childhood till presentation. And at the same time, mother also noticed that the child was thin and small compared to his peers, and they sought medical attention for this. And the child was evaluated and outside at same time, and faulty feeding was noticed and it was corrected. And after that, the child started gaining adequate weight. And during this period, mother noticed that the weight gain is adequate, but inadequate gain in height. And during 3 years of age, when the child was 3 years old, mother also noticed that increased thirst, like the increased frequency of drinking water. And mother also noticed complaint of increased frequency of micturition. And like the child was awakening 2 to 3 times per day during the night. And was present, and during the same period, normal adequate weight gain is there, and no history of cyanosis, feeding difficulty in neonatal.
Can we wait
We
here?
are not very clear. I'm not very happy about the history.
So you said 3 years the mother noticed polyuria and polydipsia.
The sequence of event is not very clear from what you are telling. The sequence of event should be clear. What is first? What is the growth arrest is first, or what they noticed, polydipsia is first, and what was the distance between the each symptom?
If they at 1.5 year of age, the mother noticed first growth.
Okay.
And
Because,
after that,
okay. And after at how many months this complaint of polydipsia and was
it all started at 3 years of age, sir. This polyuria, polydipsia, it started
so
at 3
in
years of
between
age.
1.5 years to 3 years, there was no polydipsia, nothing.
No,
No
sir.
other symptoms other than the less growth,
Yes, sir.
which was felt by the mother, or was it is endorsed by some medical practitioner, or it was a maternal
Sir.
feeling. Maternal feeling. It was maternal feeling.
Maternal feeling, sir.
Okay.
Did the baby ever had bladder control at night time?
Sir, ma'am, no history of any no history of enuresis, ma'am, and no history of bedwetting.
So bedwetting was not there, but it was new onset. Bedwetting that started at 3 years.
No history of bedwetting, ma'am, but he used to wake up his mother.
Okay, he used to wake up.
Yes, of age.
Fine. Thank you.
Okay. So, and this gain of weight was not there and it became adequate. When these things happened, you said initially the weight gain was also not good, but they corrected in the nutrition and it became all right. That is, what is the reference period for that?
Sir, at 1.5 years age, mother noticed the weight gain is also not good and height is also not good, and there sought medical attention during that period. And and in the next 6 months, the mother noticed adequate gain in weight is there, but no improvement in height was seen.
Okay. Mother seems to be quite literate and quite observant, because it requires quite a good amount of observation to predict growth arrest or estimate growth. Okay.
Now at the 8 years of age, mother presented with the only height, sir. Only inadequate gain in height. And no history of cyanosis, feeding difficulty in the neonatal period, or sweating over forehead, or any sucrose cycle was noticed, and no history of any frequent chest infections. No history of chronic diarrhea, bulky stools or steatorrhea. No history of decreased urine output, poor urinary stream, or recurrent urinary tract infections. No history of a recurrent cough or frequent use of MDI and nebulizations.
Okay.
No history of any neonatal jaundice. No history of jaundice, no history of any regular blood transfusions in the past, no history of double vision or chronic headache. Coming to
Dr.
the
Amla,
Can
may
you
I interrupt?
justify each negative history? Why did you ask for?
To rule out any congenital heart diseases which is affecting the growth of the baby child, and to rule out chronic diarrhea, bulky stools, to rule out any malabsorption syndromes, and no history of decreased urine output, poor urinary stream, to rule out any acute or chronic kidney disease which is affecting the growth of the child. History of recurrent cough, any asthma or any recurrent cough, frequent use of MDI is also ruled out asthma and the cystic fibrosis also. And no history of prolonged neonatal jaundice, lethargy, constipation, and abdominal distension. This is due to rule out congenital hypothyroidism. No history of jaundice or bleeding due to any transfusion-dependent anemia the child is having, and double vision, blurred vision, it is due to any ixols, pituitary adenoma like that causing growth problem.
You said child has polyuria and polydipsia.
Yes, sir.
So why do you think this child has polyuria, polydipsia? What is the reason for the polyuria and polydipsia in this child? I think Dr. Sajini also wanted to ask something.
Yeah, I would like to you to elaborate about the polyuria, polydipsia. What happened from 3 years till 8 years, if you can.
And why they didn't act on it from 3 years to 8 years? They didn't do anything for the polydipsia, polyuria. They didn't consult doctor.
They have consulted the doctor, ma'am. The patient is still having that issue, but it is during my history taking, it decreased somewhat compared to previously, but it is not like exactly polyuria, polydipsia, but increased frequency is there. Like the child takes 10 to 15 times drinks water in a day, but it is like only 2 to 3 sips of water.
So, fine. And what are the differentials that you will consider when the child has polyuria, polydipsia?
Ma'am, DI, ma'am, and CKD, ma'am.
CKD, okay. Anything
Yeah.
else?
And DK?
And
DK you will also have.
DK also, ma'am.
Yes.
With the commonness, DK would come first, and say DI and CKD will come down.
Yes. So any negative history
Number
about
one,
that?
let us revise something, basic things for benefit of all, because so many people are attending. Can you tell me what is the affection of height and weight in congenital heart disease? Which type of congenital heart disease affect height more? Because we are interested in height.
So which type of congenital affects
Means
height
there are
more?
two varieties of congenital heart disease, cyanotic and cyanotic. So
So
out
the
of them,
cyanotic affects more, sir.
yes, correct. Cyanotic affects both height and weight.
Yes, sir.
Cyanotic generally would affect weight.
Only weight only.
Weight only. Weight affection is much more than the height affection in cyanotic. So, okay.
Yes, sir.
That is
Can you tell us the reason why it is so?
Sir, in cyanotic, sir, increased work of breathing will be the hypoxia, which leads to this.
So increased work of breathing is there in VSD also.
No, sir, hypoxia, increased metabolic rate will be there.
Increased metabolic rate it is in both the groups, but the hypoxia is more in cyanotic heart disease. Tissue
Hypoxia is more in
hypoxia.
cyanotic one.
Yeah, that is the reason. Yeah.
okay. And normal growth pattern. Just enumerate normal how height rises for the benefit of all. There are 52 people participants. Just revision for the.
Sir,
At birth, how much? First year, second year, third year, fourth year,
at
fifth year.
birth, it will be like first at birth, like the child will be around 50 to 60 centimeter like that. But in the first year, it grows like 25 centimeter, and in the second year, it grows to 2 centimeter, 5 centimeter.
No.
50 to 60 is a very wide range. 50 to 60 is a very wide range for the length.
There is hardly any baby of 6
Not
centimeter
60.
in India.
Yeah.
So most of the
It
babies
would be
are
60.
between 47 to 52.
Sir, in
Most
second year,
can
it
go.
will be like 12.5, sir. First year 25, second year 12.5.
Yes. And thereafter.
Just remember.
Sir,
Just remember
thereafter
50, 75, and 87. Simple. 50, 75, 87.
5 to 6.
0, 1, 2.
Thereafter, around 6 centimeter per year till puberty.
In puberty, sir, 10 to 12 centimeters.
Till puberty, it will obey the same rule of 6. Okay.
Yes.
And which charts we use till 5 years, and after 5 years, which chart we use?
The first till 5 years of age, we'll use WHO chart, sir. After that, we'll use IAP chart, sir. Till 18 years of age.
Why so?
Sir.
Why the dichotomy?
Sir, because sir, and sir, first 1 to 5 years of life, like growth will be affected by the nutrition and.
Yes, you are on the proper line. You are on the proper. There is a concept of first 1,000 days. So it is believed that you can change the genetic makeup by nutrition supplementation. So you are keeping a higher goals. It is these are higher goals. Hardly very few Indians make the WHO chart. The highest going child in our India is reaching around 50th centile of WHO chart, just reaching on the 50th centile. So we have chosen the higher goals because we feel that it is modifiable. Nutrition can modify the growth, may modify the growth. That's why we have kept the higher goals, and that's why. And thereafter, after 5 years, we are taken to what is from India.
India.
Okay.
Yes, sir.
Can I talk on Dr. Amla?
Ma'am?
You said polyuria polydipsia, right? There is one more reason of polyuria polydipsia, that is psychogenic. Okay, unless you quantify, I would like to say that it is more increased frequency and of urination and drinking, not polyuria polydipsia. That is one thing.
Yes, ma'am.
And the other thing is, yes, we do follow the growth charts, as Dr. Anand sir said. The growth charts for the first 5 years, we use WHO because the studies that WHO have conducted for making the growth charts, one of the center was in India, and they have included Indian babies in developing the growth chart.
Unfortunately, it was from the elite children of the Delhi.
Yes, elite children from
and
the Delhi.
so they are not representing the lower socioeconomic and poor children of our India.
Yes,
that is
and
the
that's
problem.
why we tend to underestimate.
Yes, ma'am.
You can continue.
So, to tell you the fact that whenever there is a case of short stature, you should be prepared. This is for all those who are listening. You should be prepared with the basic growth, because your discussion will start in MD exam from the basic growth, and then it will be taken higher. So be prepared with the. Now, what happens is generally it is an endocrine case. It looks like endocrine case now. Then you are prepared from the endocrine angle. So be prepared from the basic angle. That is the message.
Yes, sir.
And as you are going answering the basic things, the examiner gets impressed and then he starts asking the higher and higher questions. Okay?
Yes, sir.
Go ahead.
So no history of a chronic illness requiring repeated hospitalization, no history of trauma or bone pain, no history of a TB contact or anyone who received ATT. And the child sought medical attention at 3 years of age, which was inadequately evaluated, and they didn't receive any treatment for that. And coming to the antenatal history, it is a natural conception. The mother this is a second child for her at around 7 years of age, and it was detected by UPT, confirmed by ultrasound. And she's a registered case, and no history of recurrent pregnancy losses was there. No history of any significant maternal illness or addiction was there. And during the first trimester, mother has taken folic acid supplements, and no history of fever with rash, radiation exposure, or teratogenic drug was there. And in the second trimester, she has taken iron and calcium supplements and 2 doses of TT, and she felt quickening at around 5th month of age, and anomaly scan was normal, and no history of any gestational hypertension or diabetes mellitus. And in the third trimester, she also went on growth scan, which was normal, which was showing adequate growth, and no history of leaking PV or bleeding PV. And the boy was delivered at term pregnancy with elective LSCS, as she had a previous LSCS, was underwent elective LSCS. Birth weight was around 2.9 kg, and length was not recorded, but as the mother told, the child looked height was okay during that period. And history of insignificant, like mother gives history of during the first day of life was the child was lethargic, irritable, and was given some medication which was no documents were available, and only oral history was available. No history of any NICU stay, and was discharged on day 9 of life, as a mother was underwent LSCS, was discharged on day 9 of life, and was started on exclusive breastfeeding. Coming to the developmental history, no developmental delay was noticed, and age appropriate milestone was achieved. And at present, the child is in 2nd standard with good scholastic performance. No history of psychosocial and neurobehavioral problems. And coming to the family history, no history of any significant illness in the family. No history of delayed attainment of puberty and short stature in the family. No history of any sudden unexplained death or congenital anomalies in siblings.
When you are asking the history of short stature in the family, you are asking where, up to what level?
To rule out any familial causes only.
Up to what level? What you're going to grandmother, grandfather level, or on both sides, or how you are going?
Sir, on both sides we are
Just mother
asking.
and
Sir,
father. You're considering both only mother and father, or going a generation behind that?
Sir, 2 generations, sir.
Because many a times this looks like probably endocrine case, but many short stretchers have a genetic origin, and the mother and father are apparently tall, but one of the relative in earlier generation is short. And that gene is not expressed in the mother or father and gets expressed in the next generation. This can happen. This happens routinely in the practice. A much commoner thing. Just I wanted to highlight that. So you should go when there is a short stature patient, not in this patient. This patient is not grown for so many years, but routine short stature patient who is not growing well, then you should go to one generation behind what you are. If you have gone, that's very correct.
Yes,
Maternal and paternal, grandmothers and grandfathers' height should be noted.
Yes, sir.
Okay.
Yes.
So, Dr. Amla, did the mother give the history of lethargy, or was it on questioning she told you?
On questioning, she told, ma'am.
Okay. So, why are you suspecting that history?
Ma'am, was suspecting any history of hypoglycemia.
So, what?
Endocrine causes on.
Okay. Okay, we'll discuss later. No problem. Go ahead.
Coming to the nutritional and socio-economic history, the requirement of the calorie requirement for the child is like 1600 calories. The child is receiving 1000 calories and a deficit of 600, which constitute around 40%, and protein of 25 grams. The child is receiving only 20 grams of protein per day, and he consumes a mixed diet. And as the child comes from upper lower class, and according to modified Kupuswamy scale 21, the deficit can be explained by this, as they are not able to afford. And
what is the current weight of the child?
So current weight of the child is 15.8, sir.
And age is 8 years.
Yes, sir.
Okay. And fitting into what centile?
Sir, it's third centile, sir. Less than third. Sorry, sir. Less than third centile.
Okay.
Yeah. So how do you justify that he was gaining adequate weight till now? Like mother said, but do you think that right now the child is only 15 kgs? So will you say that he has gained adequate weight? And with the background history of polyuria, polydipsia?
Ma'am, compared to weight, ma'am, height is very low compared to weight, ma'am.
Okay, justifiable, but still weight gain is also very poor.
Yes, ma'am.
How much deficit will cause how much weight loss? Is there any equation? How much deficit for how much period will cause how much weight loss or gain?
How much deficit does? It's like
I'll tell you, about 500 kilocalorie deficit for a week will lead to 1 lb weight loss.
Yes, sir.
This is Nelson, nothing out of Nelson. Okay. And similarly, 500 calories more for 1 week will gain 1 lb.
Yes, sir.
Will it be age specific also, just out of curiosity? This 500 calorie.
So 500 calorie.
For 1 pound weight gain or weight loss. I wanted to ask Deshpande sir actually.
Yes. What is the question?
Yeah. Will this be age specific also? For example, a 2-year-old child and say 10-year-old child. Will the response be same for weight gain or weight loss?
That is not actually mentioned in Nelson, but this is what I'm telling is right from the death.
Right. Dr. Sajali, you have any views on this?
No, sir. So I'm not aware of this, whether it is age specific.
Right. But this is right from the nutrition chapter of the Nelson,
right.
Where this specific dynamic action of the food and this everything is mentioned. There they have mentioned it.
Yeah. Many a times, what happens is students take the dietary history, but there is a lot of disparity between the calories and proteins that you tell us and the weight or height of the child. So that obviously should not be there. It shouldn't be too obvious. Little bit of difference is okay, but it shouldn't happen that the child is taking 500 calories and the child is, well nourished, or the child.
If there is a child is adequately growing according to the anthropometry, don't show any deficit. That is my take to you. In exam, if your child is around 50th centile in growth and height, weight, then don't show in nutrition history some deficit. Even if you feel, because your calculation are gross, they may be wrong. You are calculating in 5-10 minutes out of the 30 minutes of what you get in exam. So if there is child is growing properly, so don't show deficit in the nutritional history.
Yes, sir.
Understood the point? It gives
a
paradox. It gives a paradox.
Yeah, don't create a paradox. Yeah.
Yes.
An examiner picks up the paradox.
Even sometimes what happens is you tell us that the calories are extremely deficient, but the protein is good. So generally, Indian food is not rich in protein by and large, isn't it?
Yes.
So even that becomes a paradox. So be careful what you tell us in nutrition.
Yes, sir.
And we know that there are limitations what nutritional history you can take in 40 minutes. So everybody knows that, but as a protocol, it is because you have to take everything in 40 minutes. Okay.
Yes, sir.
So, Dr. Amla, one more question I have. Do you think if there is nutrition deficit of 600 over a long period, if that's why the child is not growing also? Don't look at the anthro, just because height is more affected than weight, you are thinking endocrine. But in general, if you say that the calorie deficit is it's around 40%, right?
Yes,
so is this the one reason that you can say that the child is not growing?
Yes, ma'am. Yes, ma'am.
Okay.
You can.
Okay, fine. Go ahead.
Coming to the summary, ma'am, this is an 8 years boy, second born of a non-consanguineous marriage, inadequately gaining height as compared to pace since early childhood, with a polydipsia and polyuria, and also having a nutritional deficit. And according to the history, coming to the differential diagnosis, maybe like most commonly nutritional one. And I would also like to exclude endocrine and genetic and constitutional and chronic kidney disease, ma'am.
So nutritional should always be on the topmost, because endocrine causes of short stature are very rare. They account for only hardly 2 to 10% of kids referred for short stature. Okay.
Yes, ma'am.
If you're sure about the polyuria and polydipsia, will you put endocrine first? Dr. Sajili, I wanted your opinion.
So yes, definitely, unless there is any psychogenic cause of polyuria or polydipsia, but it has to be documented that there is polyuria and polydipsia. The way she described that he was only having sips of water, I'm not very sure whether we'll call it polyuria in the history itself, unless we count.
But if child is getting up in the midnight
yes,
to urinate, it is definitely polyuria.
Yes, sir.
The mother must be telling her to
Yeah.
It is sort of a wishful thinking of mother. But if she's getting up in the night and passing urine, it's a definite sign that it is a polyuria of either renal origin or a CNS origin.
Yes, sir.
Yes. On examination, the child was sitting comfortably and cheerful, and he was oriented to time, place, and person. And temperature was measured on the right axilla, temperature of 98.6 Fahrenheit, pulse rate of around 90, regular normal volume, no radial delay, all peripheral pulses are well fed, and sleeping heart rate was around 80, and respiratory rate of 22, and the blood pressure was 96/56, which is taken in right arm in supine position, and 50th to 90th center, and saturation of 99%, maintaining at room air. And coming to general examination, mild pallor was present, no icterus, cyanosis, no clubbing, no lymphadenopathy, no neurocutaneous markers were seen, no signs of micronutrient deficiency like cheilitis or angular stomatitis, and hyperpigmented knuckles were seen. And on head-to-toe examination, flat occiput was seen, no overriding of sutures, frontal bossing, thin hair, And along with that, areas of hair loss were seen over the scalp, and depressed nasal bridge was seen, and small eyes and nose, which are suggestive features of mid-facial hypoplasia likely, and small philtrum, low set ears, and thick and pointed hyperkeratotic nails, long slender fingers and toes, and coarse skin, and on examination was inspection was found to be having a very small penile length. On examination, it was found to be a stretch penile length of 2 centimeter.
Okay. Is there any squint or something, esotropia on one eye?
Small.
There is some amount of antimangular slant.
Small. It is there. No squint is there, but small eyes.
Okay.
Coming to anthropometry, height is around 95 centimeter, and expected height of 50th centile is 126 centimeter for his age, and the Z-score is less than 3Z, which is severely stunted, and weight is 15.8 kg, and expected 50th centile weight is 25 kg, and it is less than -3Z with severe undernutrition, and BMI is 17.5. As it is an age-independent factor, expected 50th centile was 15.74, and Z-score of 1 to 2Z, which shows like on assessing it is like overweight, and upper segment length of 47 centimeter, lower segment of 48, upper segment to lower segment ratio of 0.9 is seen, and arm span of 101 centimeter. And coming to father's height, it is 161 centimeter, mother's height of 158, the mid-parental height of 166 centimeter. This is an anthropometric with a target height of 160 to 172 centimeter. And this is an IAP chart for a 5 to 18-year-old boy. In this, at the first, it is showing like at 2 years of age, the weight is around 10 kg, and height is of around 70 centimeter. And after that, they haven't got measured, was done at local Angalwadi center, which the records were not available. And now at 8 years of age, height is 95 centimeter, less than 3Z, and weight is 15 kg, like less than 3Z. On the side, it is showing target height range. Like after plotting the target range height also, it falls way below the target height range. So it consider, based on this anthropometry, I like to most consider pathological short stature causes I would like to evaluate.
Yes.
And
so this
coming to
growth chart,
systemic,
you can focus back again. So it's a very good growth chart. You can see that the height is more affected than the weight. Okay, in the conditions, we only consider endocrine, but syndromic causes also can present like this. Okay. Syndromic shorts, metabolic causes or syndromic causes can also have this presentations like glycogen storage disorders and all.
Height age you have to talk about. What is the height age?
Yes.
Ma'am, height age of 3 years, ma'am. Chronological of age of 8 years, height age of 3 years, bone age of 3 to 4 years. And coming to systemic examination, on central nervous system examination, higher mental functions and cranial nerves and motor system and sensory all were normal. On general gastrointestinal, no significant findings were there, no organomegaly was seen. And serious S1, S2 were heard, no audible murmur was heard. And respiratory, no bilateral equal air entry was there. Chest was clear. And I would like to summarize the case after this brief examination. This is an 8-year-old boy, second born of a non-consanguineous marriage, inadequately gaining height as compared to peers since early childhood. The history of polydipsia and polyuria, with adding a nutritional deficit factor. Along with that, the child also had midfacial hypoplasia and micropenis, and on evaluating was found to be having severe stunting and overweight, as the height for age is way less than a weight for age, and significantly very lower than target range. And after this, I would like to come to the differential diagnosis of, I would like to entertain the causes of endocrine, constitutional, and lastly, nutritional.
Dr. Amla, constitutional will be very less likely in this, because you are saying he's way below his target height.
Constitutional is unlikely.
You have not given any history of delayed puberty or in parents or anything, so less likely.
No, ma'am.
It is not likely only.
What is the short way to rule out constitutional?
After attaining the puberty, they will
No.
So growth velocity rate.
growth velocity and
this type of endocrine will be having almost no growth rate. 1 or 2 centimeter may be there, but in constitutional they will be having little less, but they will be having a good significant growth velocity rate.
it's a growth velocity.
If you check,
Yes, sir.
check growth 1 year apart, there normally it should be around 6 centimeter minimum, 5.5 to 6 centimeter.
Yes,
So
sir.
if it is constitutional, it would be little less, but in
Yes,
such a
sir.
type of endocrine or other pathological causes, it is significantly less. There will be hardly any growth.
This patient has like growth velocity like less than 3rd percentile, sir.
Okay.
So what was the growth attained in last 1 or 2 years?
Sir,
How many
Sir,
centimeters plus?
sir, last no documents were available, sir, but based on mother's history only we have taken this, sir.
In between, she has not come anytime. So,
No, sir, they haven't. Last they had sought medical attention at 3 years of age, sir. At that time, the child was around 68 to 70 centimeter.
okay.
Okay. So, Dr. Amla, why are you thinking it's as panhypopit?
Ma'am, panhypopituitarism, ma'am, because other mostly
Of
growth
polyuria and polydipsia, okay?
polyuria polydipsia, ma'am. One history of hypoglycemia was there in the neonatal period.
Okay.
And
So hypoglycemia is because of which hormone deficiency? In a multiple pituitary hormone deficiency?
because
It's because of growth hormone.
growth hormone.
Yeah. So why pan? That's what I'm asking. It is because maybe you are thinking of polyuria.
Ma'am, polyuria polydipsia was also there, ma'am. And other than that, coarse skin was also there.
Okay, there was alopecia, like patchy hair, right? Thin
Also, ma'am.
So how was the dentition? When you are thinking of panhypopituitarism, you have to look at the dental hair. If there are incisors are present or not there, or single incisor is there. There are some syndromes, no?
Any midline defects?
Midline defect, septoptic dysplasia, or something like that. Syndromes are there, where you have a problems with the pituitary. External manifestation is a faulty dentition. So you can get a clue from that.
Yes, sir.
Yeah. And what about the nails? You mentioned about nails were dystrophic. Nail issues were, right? What do you suggest?
Hyperkeratotic nails were there. Pointed, long and pointed nails were there, ma'am.
So what does that suggest?
Ma'am, that suggests mostly hypothyroidism features like that, ma'am.
Okay. Or it can be an autoimmune also, right?
Yes, ma'am.
It can be.
Autoimmune, sir. In autoimmune pituitary affection, they can present with autoimmune disorders plus pituitary affection. APS, like. Okay. So how will you go ahead with this patient?
Yes,
First thing that you will do.
Ma'am, first we'll with the growth chart, ma'am. After that, I would like to do basic investigations, ma'am.
How did you check for this? This is again asked in examination. Stretch penile length. How to check for it?
Sir, I will stretch the. Sir, I didn't get you, sir. Voice was.
You said no, the penis, there is a micro penis,
Yes,
and
sir.
the length is 2 centimeters. You said no, something like that.
Yes, sir. Yes, sir.
So how to check for this stretched penile length?
Sir, we had
Examiner sometimes will ask you to show.
Yes, sir. We have to stretch the penis and measure it at the root of the penis. We have to, from there we have to stretch it and measure the length, sir. Like anything less than 2.5 centimeter or less than.
You should use a plastic ruler.
Yes.
Not your tape. The plastic ruler will generally suprapubic fat is always there, so you have to press that suprapubic fat and
Yes.
by the plastic ruler. Typical which is available 6 inches ruler, 15 centimeter, that will be useful rather than checking with our normal tape which we use for the checking our head circumference or mid-arm circumference. It will not do the work there because the suprapubic fat many times interferes with the real length. There is a especially in adolescent chubby child, suprapubic fat is so much, you have to dip it, that ruler, in the suprapubic fat. And understood?
Yes, sir.
And you were saying something about definition of micropenis. Can you elaborate again?
Ma'am, stretch penile length of anything less than -2 standard deviation, ma'am.
Yes. So because before you said 2.5. So 2.5 is at birth. Okay. It differs as per the age.
Yes, ma'am. In newborns, 2.5 centimeter. Like.
And we do have graphs for penile length. Okay. Indian standards are also available. So you can use that for micropenis definition or anything less than 5 centimeters after 5 years of age. Okay. It's a general rule, not a definitive. So would you like to confirm polyuria polydipsia?
Yes, ma'am. First, I would like to confirm the bony growth chart. After that, bone age, and after that, I would like to whether the history of polydipsia was accurate or not. I would like to evaluate that one also, ma'am.
Yes. So how do you do that?
Ma'am, we'll just 24-hour urinary collection, ma'am. And polyuria, it is like greater than 5 ml per kg per hour or greater than. I would like to do in IO charting. And
okay, so you are right. Don't worry. Go ahead. So you will quantify.
Yes, ma'am.
For 24 hours. Okay.
Yes, ma'am.
So in polydipsia, you will measure all the liquids that the child is taking. Okay.
Yes, ma'am.
So what happened in this child? What was
ma'am, we evaluated this after the child got admitted. We have just 24 hours urinary input. I was chatting with it, ma'am. Like it was the child didn't have any polyuria, and polydipsia also didn't have any polydipsia, ma'am.
Okay, so how do
you define polydipsia? How do you define polydipsia?
Polydipsia as greater than 2 liters per meter square per day, sir.
Yes. So you are saying there is no history of polyuria, polydipsia. Then how do you? Yes. The quantification rules out. Okay.
Yes, ma'am.
Okay, fine. So now what will be your diagnosis? Like once you have ruled out that there is no polyuria, polydipsia.
Yes, ma'am.
Okay, so only short stature. So can it be an isolated growth hormone deficiency?
Yes, ma'am. It can be an isolated growth hormone deficiency, ma'am. Mostly, as the problem started after like first initial, it was like weight gain, weight and height. After that, 2 to 3 years of age, most concern was height. Weight was okay, and only height was the problem. I like to mostly think of height, isolated pituitary only. Only, ma'am.
Okay. And one more thing, what are the other causes of short stature, endocrine causes of short stature other than pituitary?
Ma'am, hypothyroidism, ma'am, and CAH, ma'am, and
CH? No, CH depends on whether they are treated properly or not. Okay. Oh, CH can be tall also.
Yes, ma'am.
So what are other causes? Cushing's? Will you say Cushing's as a cause of?
Cushing's, ma'am. Any other cause like inner.
See, there are
steroid causes like if steroid intake also one
So
thing.
yes,
And
so Cushing's, anyway,
yeah.
Cushing's, exogenous or endogenous Cushing's?
Exogenous or endogenous?
Yes, long standing. Okay, and then the other causes pseudo hypopara.
Pseudo
There are
hypopara.
only 4 causes of endocrine short state. Okay, and even hypothyroidism may not always present with short stature.
Yes, ma'am.
Okay.
And coming to the investigations, we did the first started with the basic investigations. HB was 8.9 gram per deciliter, TLC of 8,200, and poly of 36, and lymph 50, mono 4, eosino 7.
In between the voice is this. Can you repeat it once again? Your voice was not.
So we started with the basic investigations. Hemogram first we did. HB was 8.9, TLC of 8,200, and DLC of poly of 36. And
Once before that, I would like in the before going to investigation in the differential diagnosis, why it is not a RTA?
Sir, the child didn't have any other history of increased. No rickets was there, sir.
No rickets was there. That is
On
one
examination. And sir, only height is affected, sir.
No. But RTA
so
is
that is
present with height
definitely-
affection.
Sir, both.
Go ahead.
And what was the Tanner staging? I forgot to ask you about that. What was the testicular volume?
Prepubertal, ma'am.
Constable?
Sir,
But-
testicular volume was, ma'am, 2 ml, ma'am.
Bilaterally 2 ml. Okay. Both the
Ah, it
testes
is.
were descended.
Yes, ma'am. Both testes are descended. It was around 2 to 3 ml, ma'am.
Go ahead.
Coming to the basic investigations, hemogram, HB was 8.9 gram per deciliter, TLC of 8,200, DLC of poly 36, lymph 50, mono 4, eosino 7, and platelets of 6,53,000, like which is showing a picture of microcytic hypochromic anemia. And biochemistry, like urea was 34, creat was 0.4, blood sugar was 103, and sodium potassium were like 136 and 4.9. Bilirubin was 0.2, OTPT were normal, and total protein albumin globulin was like 6.3, albumin was 3, globulin 3.3, and we did an VBG to rule out pH 7.394 and CO2 of 37.6 and bicarb of 23.2 and lactate of 1.1. And after doing this basic investigations, we did a bone aging also. It was showing like bone age of around 4 years, like way less than.
What was the anemia like? Microcytic? What was the
Microcytic hypochromic anemia, ma'am.
Okay.
And other investigations we did like vitamin D3. It was 20.3, like at the exact cutoff of like deficiency and insufficiency. And we did a thyroid profile, which came to be normal. TSH was 5.84. And after ruling out all these things, and bone age also, and we did a growth hormone stimulation test with the clonidine. Like we have given a 75 mics of clonidine for the child, and we have taken the sampling and blood sugar subsequently at 0 hours, 30 minutes, and 60 minutes, and then again at 90 minutes. And during this, we have did the frequent sampling of blood sugars and blood pressure monitoring, and growth hormone sampling we did. During this period, the growth hormone, there was no any increase in growth hormone, like it was clearly showing a picture of growth hormone deficiency. And cortisol levels in the morning were 6.53 in the morning, and in the it was normal. And then LH and FSH levels also became to be normal. Okay. And after evaluating this cause of in this up to this, we have come to this mostly it looks like a growth hormone deficiency, single hormone deficiency endocrine cause. And after this, we did an CMRI brain, and which came to be like anterior pituitary hypoplasia with normal pituitary posterior bright spot and normal pituitary stalk. And in the mean, before this MRI, we ruled out USG abdomen and KB, which came to be normal study, and fundus was normal, and the karyotype was like 46x5 normal, and bone age was like less than 3 years. Sorry, greater than 3 years, but less than 4 years.
So, why did you do karyotype? Just out of curiosity.
Ma'am, to rule out any Nuna
Rule out what?
Ma'am, to rule out Nuna.
Noonans, how will karyotype pick up Noonans?
No, ma'am, sorry. Karyotype we did.
Karyotype will not pick up neurons.
Ma'am, just to rule out, as the child was also having micropenis and short stature.
But you said the testes were descended.
Yes, ma'am.
So you don't need to do it.
Which
Ma'am,
autosomal interested?
Just to rule out any disorders
because they
of
felt that
DSC.
the look is syndromic look. That's why they must have gone for that.
Maybe.
There's some syndromic look.
It's a syndromic
Must have
look,
tempted.
sir, and to rule out any disorders of sexual development. For that also we did
there is apparently absolutely male like there was no DSD. Yeah.
Isolated
there.
micropenis is never a DSD. You have to remember.
If they are normal looking male with descended testes, there is no DSD. In this
Isolated
patient.
micropenis is not DSD. Micropenis with some abnormalities like undescended testes or pinoscrotal hypospadiasis, then only we say it's a DSD. Okay.
Yes,
A micropenis can be normal also most of the times. Okay. So it's not always a DSD. There may be some hormonal deficiencies, partial, but not a DSD complete. So can you elaborate about the growth hormone stimulation test? Let everyone understand what we are doing now. So what you did you ask the child to be fasting overnight?
Ma'am, yes, ma'am. We kept the child fasting, ma'am, for 8 hours. After that, we have given like.
Why do we keep the child fasting? If I ask,
Ma'am, why do we keep the child fasting? Ma'am, to induce hypoglycemia, ma'am.
so basically fasting is a stimulus for growth hormone release. Basically growth hormone is released in peaks. Okay, it's never continuous flow. Pulsatile manner. So fasting will help in increasing the response. Then what we do is we give a synthetic stimulation like clonidine. What is the best thing to do growth hormone test ideally?
Ma'am, clonidine.
No,
Insulin
normally
also.
yes, insulin, but it's very risky and normally we don't do. We do a clonidine stim test.
Yes,
Okay. And growth hormone stimulation test is also not always confirmatory in partial cases. Okay. And in this case, the child was 8 years. Okay. So do we need to do priming in this child before doing a growth hormone?
No need of a priming. No need of priming, ma'am.
Why?
Ma'am, like at 10 years of age, priming is needed, ma'am.
Okay. Yes. So normally around 9-10 years, we do priming in kids, but when the bone age is not significantly delayed. In this child, you can see the bone age is hardly 4 years. Okay, so you don't need to do priming. So I'll just justify what is priming is basically we try to give them a sex steroids. Yes.
GnRH.
No, we give either estradiol or testosterone. Okay, to prime the child. And then we do the growth hormone after a week or something.
Yes.
Okay. Is there any role of IGF-1 in this child? Doing a IGF-1 levels?
Yes, ma'am. Baseline levels are needed, ma'am.
How does they help you? IGF-1 levels?
Ma'am,
okay, so normally
ma'am, if normal, we can rule out other. We can.
So
if it is
growth,
normal, ma'am, we can.
So let's start with the pathway of growth hormone. Okay, what happens is in your pituitary, from the hypothalamus, GHRH is released, which will cause release of growth hormone, right? This growth hormone will act on liver to produce IGF-1.
IGF-1.
And that IGF-1 will act on your growth plates to bring about the effect of growth hormone. Okay, some growth hormone does have direct effect on the growth plates as well, but majority is through IGF-1. So in a growth hormone deficiency, we predict that the IGF levels will be low. So normally we use that's a screening test. Okay, but these are not confirmatory because many factors affect your IGF-1 levels. So we need to do a growth hormone test.
Growth hormone.
Stimulation test, yes.
Yes, ma'am.
Okay, but IGF levels will help in monitoring the growth hormone therapy.
Yes,
That's why we do a baseline growth hormone level.
Yes, ma'am.
Sorry, IGF-1 levels. Okay. So now how do you explain the skin issues and abnormal hair, alopecia and all this in this patient? Because the thyroid is normal. Initially we were saying it may be because of thyroid.
Ma'am, it may be due to genetic causes, ma'am, and hypopituitaries.
How we are going to explain normal thyroid? Because you said on MRI there is anterior pituitary hardly existing, atrophic.
Yes, sir. Sir,
Normal T3, T4, TSH.
yes, sir. Sir, I didn't get your question, sir. Normal.
No, your MRI finding is showing there is hardly any anterior pituitary. No, it is atrophic, no?
Yes,
That's the MRI finding. MRI finding was posterior stalk intact, anterior pituitary is not seen.
Yes, sir.
Then how come the TSH, ACTH? How much is the ACTH? We have done ACTH.
Sir, ACTH we didn't do, sir, in this one. Sir, but cortisol we did, sir. It was normal, and
so only growth hormone singularly got affected. It looks like.
Sir, it looks like in this case, sir, only growth hormone got affected. Maybe due to some genetic
anatomically, whole
mutation.
pituitary is affected. Anatomically, MRI wise.
Sir, hypoplasia is there, sir. Maybe some genetic mutation which caused isolated growth hormone deficiency, sir.
Yes.
Surgically, what is your take on?
Sir, this can happen with a small anterior pituitary. Only isolated hormone deficiencies are very commonly seen.
But how to correlate? Isolated hormone deficiency, okay, but MRI image showing total atrophic and anterior pituitary and just affection of one hormone. That is a contrasting.
Yes, sir. But we have seen such cases, sir. Only because the anterior pituitary is hypoplastic. It's not completely absent or atrophic, sir. They can present with evolving deficiencies. Like now, the child may have growth hormone deficiency.
Later on, it may.
Yes, it may evolve over the time.
Or maybe once you give growth hormone, they will be exposed.
Maybe so. Yes.
Their requirement also will increase. Now, as the child grows, the requirement will increase.
Yes, sir. Definitely.
So initially, it may present as isolated growth hormone deficiency. Later, it may evolve into multiple hormones deficiency.
Yes, it can. So what do you think is the cause of growth hormone deficiency, like isolated GHD in this child? What can be the reason?
In this case, we are thinking, ma'am, some genetic mutation which led to like isolated growth hormone deficiency in this one.
Okay, I would think more of autoimmune cause because the way the child is looks like an APS, but you have to evaluate because there are some issues. Yes, it can cause hypophysitis and pituitary affection. But no, sorry, no, anterior pituitary is hypoplastic. So genetic, sorry, I'm sorry.
It looks like congenital genetic cause only.
Yeah. No, sorry. Yes, you are right.
It started very early. You can have autoimmune process very early, but it started very early. That is little against.
Yes, sir, definitely. How do you explain which hormone deficiencies manifested with age? So can you identify growth hormone deficiencies normally in first 2 years?
Yes, ma'am. Ma'am, growth, like first 2 years of age, growth is affected by like nutrition and thyroxine, ma'am. And after that, after 2 years only, growth hormone comes into play, ma'am. Like growth hormone. And after that, puberty is like sex hormones.
So this is an ICP model that you're describing of growth, right?
Ma'am. Yes, ma'am.
So, but in very severe cases of growth hormone deficiency, they can manifest at birth also, okay? Since like 1 year also, you can see very growth faltering, okay? But in severe cases, but majority of them are picked up around 2 to 6 years of age.
2 to 6.
I wanted to ask something. Your karyotyping is negative, but is there a better test you can do? Because you said It could be a genetic problem. There's a lot of dysmorphism also.
We can do
What other
fish,
tests
sir.
can you do? Fish, you have to know what the problem is, isn't it? Then you can do fish.
The microarrays.
Yeah. Dr. Sajili, what do you think?
Yes, sir. That will help.
Yeah.
So
Can
how
you
will
tell me about what is Laron syndrome?
Sir,
Laron syndrome.
so GH resistance will be there in this.
There will be?
So there will be growth hormone resistance, sir.
Okay.
Will be due to like growth hormone receptor problem.
Okay.
so how you evaluate, go ahead with this patient? How do you treat them?
Coming to the final diagnosis, ma'am, this is a pathological proportionate short stature with micropenis and facial dysmorphism with MRI finding of anterior pituitary hypoplasia and abnormal growth hormone stimulation test and normal other pituitary hormones. And have come to the diagnosis of isolated growth hormone deficiency in a case of congenital hypopituitarism. And I would like to start with injection growth hormone, ma'am.
Okay. So are you aware of how growth hormone is given in one?
Yes, ma'am. 25 to 30 will give, ma'am, mics per kg per day.
Okay. So in growth hormone deficiency, normally we'll require lesser doses compared to other causes. Okay. So you can start with 0.05 units per kg per day, and then you can gradually increase. So what are the parameters that we will look on follow?
Ma'am, ma'am, I like IGF-1, ma'am, and will
Oxology base. Most important is the growth.
growth chart monitoring, ma'am.
So what do you expect? How the child will grow after giving growth hormone? What will be the height gain in the first 1 year?
In the first 1 year, ma'am, it will grow around 10 centimeters per year.
Yeah, 10 to maximum 15 also they can grow in the first year in a case of growth hormone deficiency. Okay.
Yes, 10 centimeter per year in the first year, ma'am. After that, like 4 to 5 centimeter per year, ma'am.
Yes. And what will be the endpoint?
Endpoint. Then after that, like 2 centimeter per year. Then after that.
So if the growth is less than 2 centimeters per year,
centimeter.
Or when the patient has reached his target height, okay, that will be your endpoints. So what things will you monitor along in this patient? Now you have said that it is an anterior pituitary hypoplasia. Once we start growth hormone, what will happen is we have to monitor thyroids and cortisol. As sir said, that they may evolve after starting growth hormone. Yes. So the deficiency.
We'll monitor for TSH, ACTH, ma'am, and normal growth monitoring, growth charting.
Yes, cortisol and
IGF-1.
Yes, and IGF-1, how will you monitor? What are you going to look at? IGF-1 levels?
Ma'am, like if IGF-1 levels are normal, ma'am.
So basically, we see growth hormone we know is also having some mitogenic effect. Not proven, but they can cause. Okay, it is. So we have to monitor IGF-1 levels so that we don't give too much growth hormone. There are no proven cases that it can cause any malignancies or anything. But IGF-1 does have some mitogenic effects. So we keep IGF-1 levels below 2 standard deviations for the age and sex. And that's why we monitor IGF-1 levels on follow-ups. And according to the IGF-1 levels, we decrease the growth hormone doses if needed. Okay. So what are the side effects of growth hormone therapy?
Side effects are hypertension, ma'am. Another is gigantism.
What is the effect on the sugar?
Hypoglycemia. Sorry, hyperglycemia.
Yes.
Hyperglycemia, hypertension.
Hypertension, I'm not very sure.
It is a diabetogenic hormone. So it will increase the sugar.
Hyperglycemia, hypertension.
Hypertension, I'm not very sure. Any other defects? It can cause raised ICPs. It can cause capital femoral epiphysis. It can worsen your scoliosis.
It can also cause gigantism and.
No, when will it cause? Gigantism is when you are giving excess, no? How can it cause gigantism when you are giving a therapeutic dose? It won't. Okay. So tell me, what does growth hormone have any role in intrauterine life? Because you said growth hormone, does it have any role in the intrauterine life? Does it control the baby's growth?
No, ma'am. Intrauterine growth is affected by insulin, ma'am, and IGF-1, ma'am.
Yes, that's why the baby had normal growth at birth. Okay?
Yes.
Any other causes of acquired pituitary deficiencies which can affect the pituitary, like the way the case is presented? Can any
ma'am, any IXOL, ma'am, any pituitary adenoma?
Yes, or else, and most commonly will be head injuries or encephalitis. Yes, so you have to rule out that issue also. In
Radiation also, ma'am.
Yes, but radiation you will have definitely a chemo history of
craniopharyngioma. It is significantly common.
Yes, sir. Craniopharyngioma is also significantly common.
Craniopharyngioma presents, at least I have seen at half a dozen, not being endocrinologist cases. Half a dozen cases. It is quite common. Really, your take on that?
So I didn't get your question. Question.
Your take on the craniopharyngioma, how much common it is, how it presents?
So most of the times when we have seen craniopharyngiomas, they present with headaches and all. Hormonal deficiencies are very rare, like in 5% of craniopharyngiomas, if they're very large and affecting the pituitary, causing a lot of compression, then we have seen. They may present with growth hormone deficiency, short statures, yes, or polyuria polydipsia also sometimes.
Polyuria polydipsia, they are present with insipidus.
Yes, sir. Most of the times they just commonly this.
Because this, I initially thought the same, because this patient, your complaints are polydipsia and polyuria.
Yes.
Thought whether we are dealing with that.
Excuse me, sir, I didn't get you.
I initially thought that because of the history of polydipsia, polyuria, whether we are dealing with the initially when you started telling the symptoms.
Yes, sir.
So any others syndromic causes?
Okay, go ahead. Go ahead. You can go ahead.
Thank you.
Thank you.
It's a good presentation, Dr. Amla. Very well summarized. Okay.
Thank you, ma'am.
Yes.
Right, very nicely presented, Dr. Amla.
Yes,
and
I agree completely.
A very common short case in exam. So very commonly it will be nutritional, but sometimes you can have an endocrine or a dysmorphic child with short stature like you had this time. So this is an important topic for PG students. And to begin with, look at nutritional. It is, symmetrical, asymmetrical. All these small things are very important. And I really congratulate Dr. Amla for presenting such a nice case. And Manish sir, thank you very much for being the convener for this session. I thank
you so much, sir.
Both Dr.
Very
Anand
nicely presented. Very nice.
Madam.
Thank you so much, ma'am.
Thank you very much.
Dr. Sajni, ma'am. I'm Dr. Deshpande, sir. And Dr. Kulkarni, sir. Thank you so much.
But why the patient didn't take any medical support for 6 years? That I cannot understand. 6 years, 7 years, they didn't consult anybody in spite of such a serious
we asked actually.
Sir, they have consulted when the child was at 3 years of age, but they haven't taken any treatment, sir.
And did you go for the exome? As Rajesh was telling, you have done exome or microarray or anything?
Yes, sir.
Microarray
Sir,
or exome?
Whole
Yes.
genome
You
sequencing.
should go at least microarray, not exome.
Microarray,
Yeah,
sir.
chromosomal microarray if the possibly can be done.
Yeah.
With all dysmorphism, it may be some syndrome
Yeah.
which is not known to us. Okay.
Yes. Thank you very much, Dr.
Thank
Amla,
you.
again, and Deshpande sir and
Thank you, sir.
and we will meet you again after 2 weeks with a new case. So thank you very much. Thank you.
Thank you very much, sir. Thank my faculty for helping me very much, sir. Thank you.
Thank you.